Hello, I'm Sergio Kaiser, professor of cardiology at the Rio de Janeiro State University, and I have the pleasure of having here with me Professor Steve Nicholls. Professor Steve Nicholls, a professor of cardiology at Monash University in Melbourne, Australia. You have come a long way to this meeting, right? And so have I, because we are in South America. And the idea was to have a brief talk with Dr. Nicholls about a new drug, which is actually it's a very well-known class of drugs, which are the CTP inhibitors. They weren't very successful in recent studies because they were aimed at raising HDL cholesterol. It didn't work out very right, except for the REVEAL study, which showed a 9% reduction in cardiovascular events tracking with the CTT meta-analysis because it lowered LDL cholesterol. So obicetrapib seems to have a special property which I would like you to talk about because you conducted your lead in the ROSE study and other studies that are following.
Yeah, thanks, Sergio. It's exciting to be here. I think many of us like being on a plane for a long time for the first time in many years. We talk about repurposing drugs. This is actually repurposing a whole class, repurposing a target. CTP inhibition 25 years ago was thought to be the holy grail to raising HDL cholesterol that would lower cardiovascular risk. We'd have this whole new class of agents and we'd move on beyond LDL lowering. And there were a lot of disappointment in a number of clinical trials. One agent had some toxicity. 2 trials were stopped early because there didn't seem to be anything going on. And the 4th trial did show some benefit. It was modest, and it turns out it's got nothing to do with HDL. Yeah. I think that gave us an opportunity to take a step back and reflect on is there a future for CTP inhibition and what does that look like? And as you said, when we went and looked at the anacetrapib results of REVEAL, the reduction in non-HDL cholesterol appeared to be really important and it really tracks with the CTT analysis. Brian Ferentz led some really elegant genetic work looking at Mendelian randomization and tells us that not only is having less CTP a good thing, but it appears to be directly proportional to having less ApoB. So again, suggesting that if CTP inhibition is going to work, it's going to be by having less atherogenic lipoproteins. And so what that says to us is if we have a CTP inhibitor that lowers LDL really well, and we can design an outcome trial moving forward that's really about getting LDL lowering and not about raising HDL, then maybe we've got a path forward. So what we reported at the AHA, and we're going to see some more data, where Kaiser is going to share at this meeting, is the phase 2 data for obicetrapib. It's a very potent CTP inhibitor, and so what we're going to report here is about a 50% lowering of LDL cholesterol on top of high-intensity statin therapy. And achieving that with doses of 5 to 10 milligrams. If you go back to the previous CTP inhibitors, they're all 100 plus milligrams. So this is a highly potent agent. It appears to be well tolerated. It has really good lowering of ApoB, triglycerides, LP(a), all the things that we'd expect to see. Its HDL cholesterol raising is really good, but we park that to the side for now. And what that really paves the way now is for a new cardiovascular outcome trial called PREVAIL, which we've just launched in the last few months. This is going to be high CV risk patients who have a high LDL cholesterol despite maximally tolerated lipid-lowering therapy. And that's different than the studies of before where we said, for a CTP inhibitor, we're going to get everybody down to 70 or even lower, and then we're going to add the CTP inhibitor. In this study, the patients are going to have LDL cholesterols over 100. And that's going to, that's going to have patients who still have an unmet need in terms of LDL lowering, so they need another agent. This will be very effective at that. We think they're at a high CV risk because of that persistently high LDL, and so we think that we can lower their risk by doing that, but the clinical trial will give us the answer.
For sure, and there's a bunch of new possibilities because many patients are really intolerant to statins, so this can be an option. And also, possibly, it could be associated also with ezetimibe or with PCSK9 inhibitors. right?
Absolutely,
Yeah.
and it's an oral agent, so the cost presumably when it gets to market would be considerably less. And you know, I see us 10 years from now being in a situation where we're going to have a whole range of injectables and a whole range of new oral agents to lower LDL cholesterol, and we'll have choice. And as you said, some patients will limit the choice because they won't be able to tolerate some of the agents, but this gives them new options that we don't currently have today. But for patients where tolerability is less of an issue, we'll be able to look at the different results from the different studies and look at the cost effectiveness data, for example, to kind of try and guide what's the right way to go for a given patient.
And what about the risk of new onset diabetes?
So if the CTP inhibitor trials had a silver lining, it was this notion that consistently we saw in every single one of them that patients treated with the CTP inhibitor, no matter which agent it was, were less likely to have a diagnosis of diabetes during the trial. We understand a lot more about the biology and how HDL, for example, can impact pancreatic beta cell function, for example. We know that there's an improvement in insulin sensitivity that comes along with these agents, and we've seen that across the board. So, you know, what our hope is, in the not too distant future, we'll have an agent that has potent lipid lowering, that's safe and well tolerated, that has a long-term effect in terms of reducing the transition to diabetes, and hopefully there will be a good cardiovascular risk benefit, and that's what we're really looking for, as opposed to a 9% risk in the REVEAL study. We want to see a really robust reduction. If we see all of that, then that's a really good outcome for patients.
Yeah, and if it proves to be a safe drug, as it seems to be, we don't even need to wait for outcome studies. As long as it lowers cholesterol efficiently, it can also be approved.
And that's a question that we're asking at this point in time, you know, acknowledging that the first CTP inhibitor, torcetrapib, did have some toxic side effects. You know, the onus has been on the other programs to demonstrate that their agent's well tolerated. Hopefully we can get that to patients before an outcome trial report's out, but time will tell on that.
Fantastic. We're very much looking forward for the next results, and thank you very much, Dr. Nicholls, for being here with us.
Thank you.